A very good afternoon to EDIC Part 1 crash course students and the faculty. The class will be on general topic trauma and burn fluid electrolyte, and it will be taken by Dr. Ashutosh Kumar Garg. He is the head of the department of Kailash Deepak Hospital, Delhi.
Good afternoon, dear friends. Today we will discuss some important topics related to the EDIC 1 exam. First, we discuss the general topic. So in general topic, we will discuss different parts of the curriculum so that we can understand what is the types of question asked in the exam. Basically, there are two types of question. One is A type question, another is K type question. In A type question, only one answer is correct. And in K type questions, there are true false type questions. So you have to give response to each and every option, whether it's true or false. Okay, so I'm starting with the general topic. First question is, a 35-year-old woman is evaluated in emergency department for fever, severe epigastric abdominal pain, nausea that have worsened during the course of 12 hours. She denies any medical history. Her father has a history of gallstones. Vital signs, temperature 38.4, heart rate 115 beats per minute, blood pressure 90/60, respiratory rate 19 breaths per minute, saturation 93% on 2-liter nasal cannula. After blood is drawn for laboratory testing, she is given 4 liters of ringer lactate over 4 hours. She is also given IV morphine for pain and vancomycin and cefepime for fever. Abdominal ultrasound is equivocal for GB wall thickening but shows pericholecystic fluid and dilated pancreatic duct. The pancreas appears inflamed, but no necrosis or cyst is noted. Critical care service is consulted for severe pancreatitis. Vital signs after 4 liters of crystalloid are temperature 102 degree Fahrenheit, heart rate 109, blood pressure 110/75, respiratory rate 22 breaths per minute, saturation 91%. Lab test showing the BUN 45 milligram per deciliter, creatinine 1, SGOT 235, SGPT 129, amylase 2023, bilirubin 2.9, lipase 4320, WBC count 14,000, hemoglobin 15.5, hematocrit 47%, platelet 4,50,000, lactate 2.1. Which of the following principle applies to this patient management? Immediate CT with contrast will provide the most prognostic information. Empiric antibiotics should be continued because they will decrease her risk of death. Initially, she should be given bowel rest because enteral feeding may worsen prognosis. Chest radiograph may be helpful in determining her disease predicted mortality at 30 days. Further, IV fluid will decrease her risk of death. So what is your take in this question? So basically case of the acute severe pancreatitis. So somebody has given answer D. Okay. So answer is D. Option D means chest radiograph. Why? You can speak also. Unmute yourself when you can speak. Bicep. Bicep scoring. Very good. So bicep scoring is very important in this question because this score is known as blood urea nitrogen more than 25, impaired mental status, search response, age more than 60, and pleural effusion. So in chest X-ray, you will get to know the pleural effusion is present or not. If it is present, it means the mortality is high or because risk is high. So a score of 3 or more, significant increase in mortality in patient with acute pancreatitis. So presence of pleural effusion will increase score from 2 to 3 and this will increase her 30-day mortality. That's why this is very important. What were the other options? Immediate CT with contrast So we don't go for immediate CT with contrast. Empiric antibiotic, we don't use empiric antibiotics in acute pancreatitis until unless there is a risk of infection or some other source of infection is already present. Then bowel rest. So nowadays we don't give bowel rest in case of acute pancreatitis. Then further IV fluid will decrease your risk of death. Not like that. So IV fluid will not decrease the risk of death. So answer is the D. Because of pleural effusion, bicep score will increase from 2 to 3 and the mortality will be high. So next question. A 24-year-old woman with a history of depression is brought to emergency department for lethargy and confusion. Patient was last seen by family about 8 hours ago. Emergency medical service personnel has found an empty bottle of acetaminophen at the scene. The patient has a Glasgow coma score is 10 but hypotensive. She requires a 2-liter bolus of IV fluid to stabilize her blood pressure. Laboratory finding aspartate aminotransferase 54, alanine aminotransferase 32. So SGOT, SGPT is almost in normal range. Alkaline phosphatase 110 unit per liter, albumin 3.8, INR 1.2, lactate 1 milligram per deciliter. ABG showing pH 7.35, PaCO2 35, PaO2 95, acetaminophen level 400. ECG showing normal sinus rhythm. Which of the following is the most appropriate? Next step. Naloxone, vasopressor, intubation, observation, and acetylcysteine. So answer is E, and acetylcysteine. So this simple question, because we know the acetaminophen poisoning is very favorite topic of the EDIC 1 exam. So they will ask each and everything about the acetaminophen toxicity, because that is the most common toxicity in the Western world. So you should read about acetaminophen toxicity in length and breadth. So that's why I have deliberately put this question in this context, so that you can understand the value of this topic. So acetamin for toxicity, there are 4 clinical phases. Phase 1 asymptomatic, phase 2 right upper quadrant pain, hypotension, phase 3 jaundice, hypoglycemia, and phase 4 is recovery. And there is a axis of NAPQI, NAPQI. So N-acetyl P-benzoquinoamine axis is the problem, and N-acetylcysteine, this replenishes the depleted glutathione reserve in the liver and enhance non-toxic metabolism of the acetaminophen. And for overdose stratifying, we have the Rumack-Matthew nomogram. So you have to read each and every minute detail of this acetaminophen toxicity by 1 or 2 books at least, so that no question should be left of this topic, because this topic is very vital in the exam. Most probably 1 to 2 questions definitely asked from this small topic. Regarding the Sengstaken black mouth tube and its use in upper GI variceal hemorrhage, which statement is true? It has 4 ports, must be stored at 4 degrees centigrade, requires insertion via the oral route. Rebleeding is common after deflation of gastric balloon. The tube should be removed within 12 hours of insertion to prevent pressure necrosis. So answer is D. Rebleeding is common after deflation. Okay, so answer D is correct because it has 3 ports: gastric balloon inflation, gastric aspiration, and esophageal balloon inflation. Unlike the Minnesota tube, which has additional 4th port to enable aspiration of the esophagus to reduce the aspiration risk. So this is also again a very important topic, Sengstaken black mouth tube. It is commonly asked in the exam, so you have to read each and everything in detail about this topic. So basically, putting the question in this crash course is the high yield topics, which is commonly asked in the exam. Not necessarily they will ask the same question, but definitely they will ask from the same topic. So my aim is to give you hint about the important topics and some salient features of that particular topic, so that if the question repeats or the question almost same, so you can crack that question. Otherwise, my suggestion is that when you make a list of some high topics, you have to read those topics in length and breadth in every detail. So this SP tube is useful in massive upper GI vesical hemorrhage and it helps to control bleeding in up to 90% of cases. But when you remove the tube, there are chances of rebleeding in about 50% of cases after deflation of the balloon. And it is recommended that tube is removed within 36 to 48 hours. The next question. Which statement regarding trolley is true? Volume overload is the principal problem. Mortality ranges from 5 to 25%. It is an immunological diagnosis. It is an IG mediated. Trolley is physiologically distinct from acute lung injury. So your answer is B. Okay. Anything else? Some differs from that B. Okay. So answer is B because it's a clinical diagnosis based on temporal relationship between transfusion of blood product and development of acute lung injury. Usually it develops within 6 hours of the transfusion. The same mechanism of capillary leak and non-cardiogenic pulmonary edema underpin trolley and other causes of acute lung injury. So this question is also easy, but the topic is very important because trolley is definitely asked one question in the exam. So they will ask which blood products causes maximum incidences of trolley, whether it's a PRBC or FFP or platelet. So, and how many hours it develops, what is the treatment, what is the rationale, why this happens. And so they ask almost 10 to 12 different type of questions from this small topic trolley. So you can read this topic from any book. It is given beautifully in some books. So this is again a higher topic. Then next question. A 23-year-old man has been ventilated on the ICU for 3 months following a traumatic brain injury. He has received no sedative medication for last 5 weeks, has had a full metabolic screen, which is unremarkable. CT brain scan is unremarkable. Patient has simultaneous eye opening during waking hours. Cranial nerve reflexes are intact, no recognition of surroundings. He flexes to painful stimuli but will not follow a command. He shows no social smiling or apparent recognition of his relatives. His condition is best described as persistent vegetative state, minimally conscious state, coma, brainstem death, locked-in syndrome. So what is your take? A. So any other option? Would you like to say? Why persistent vegetative state? Because this condition is more than a month. That's why the answer is persistent vegetative state. So wakefulness without awareness is the vegetative state. And this vegetative state, if remains for more than a month, it's a persistent vegetative state. And if it remains more than 12 months, it is a permanent vegetative state. What is the minimal conscious state? Minimal conscious state is a variant of persistent vegetative state. These patient has some degree of awareness that may be able to obey a simple command or a limited interaction with the environment, like social smiling or some mood disturbance. Coma is a pathological state of eye is closed unconsciousness from which patient cannot be aroused to wakefulness. It is usually temporary and may progress to full recovery, death, or persistent vegetative state. Brainstem death means loss of all cranial nerve reflex and loss of cardiorespiratory homeostasis. In locked-in syndrome, awareness is preserved, which may be caused by insult at the level of midbrain, such as CPM, central pontine myelonesis, or basilar artery thrombosis. In locked-in syndrome, there is a quadriplegia and loss of function of lower cranial nerves. So patient is almost totally void of means of interaction with the world, despite fully awareness. So patient is fully aware, but cannot communicate with the environment. Vertical eye movement and blinking may be preserved. So patient is listening each and everything, patient is understanding each and everything, patient is aware, but patient cannot interact, because there is a quadriplegia and loss of function of lower cranial nerves. So this is the locked-in syndrome. So you should crystal clear in your mind, what is the vegetative state, what is the minimally conscious state, what is the coma, what is brainstem death, and what is locked-in syndrome. And vegetative state present for more than a month, it's a persistent vegetative state. If vegetative state persists for more than a year, it's a permanent vegetative state. Okay. Next, a 71-year-old woman is admitted to the hospital with diarrhea, having been discharged from hospital 15 days previously following treatment metronidazole for C. difficile infection. Past medical history includes hypertension, ischemic heart disease, type 2 diabetes. She also had a C. difficile infection 3 months previously, which was also treated with metronidazole. She is having 5 to 7 stools per day, which are positive for CDI, C. difficile toxin. Examination and investigation shows heart rate 95, blood pressure 108/76, temperature 38, creatinine 94 micromole per liter. It's around 1 milligram per deciliter. White cell count 12,000, and most appropriate therapies: oral metronidazole, oral vancomycin, fecal transplant, oral fidaxomicin, oral rifampicin. So somebody has given the answer D. Okay. Why oral fidaxomicin? Because there is a history of recurrence. So patient has moderate CDA infection, oral metronidazole would be an appropriate agent of choice, but she has a history of recurrent CDI 3 months ago, with recurrence 2 weeks ago, and then the current infection. So current infection should be treated with fidaxomicin to decrease the risk of further recurrence. What is severe case of CDI? Severe means not responding to oral vancomycin, should be treated with high dose oral vancomycin plus minus metronidazole or oral fidaxomicin. Oral rifampicin or IVIG can be used, but there is no evidence to support the use of these agents. Fidaxomicin, basically it's a macrocyclic antibiotic, undergoes minimal systemic absorption, high fecal concentration, and studies shown that fidaxomicin is non-inferior to vancomycin in the initial core of CDI and superior to vancomycin in reducing recurrence. So whenever there is a mention of the recurrence in the question, then fidaxomicin is a better choice than vancomycin. But if you want to start with the first episode of CDI, you can use any fidaxomicin or vancomycin, because the fidaxomicin is non-inferior to vancomycin. So you can start with the vancomycin. But when there is a case of recurrent CDI, then fidaxomicin has is a better choice. And fecal transplant rarely has adverse effect and causes resolution of CDI in 81%. It is used as a last resort, but not the first resort, because of practical problem, aesthetic concerns. That's why this is not the first choice. So fecal transplant can be used in recurrent cases, but it's a last resort. So question is it available in India? So nowadays it is available in India, because earlier it was imported, but nowadays it is available in India. So question number 7, the following are common laboratory features of toxic megacolon except metabolic alkalosis. Metabolic alkalosis, hypokalemia, raised hematocrit, anemia, leukocytosis, left shift. So which is not a feature of toxic megacolon? So this is also a very important high-yield topic, toxic megacolon. Answer is C. Okay, C means raised hematocrit. Okay. So enteral loss of potassium and fluid may cause volume depletion, hypokalemia, and metabolic alkalosis, which carries a poor prognosis. Although these patients are often volume depleted, but anemia is usually due to blood loss per rectum with a lower hematocrit. So leukocytosis is seen as a component of inflammatory response, left shift in severe inflammation or infection. A greater proportion of immature neutrophils are present in circulation due to excessive cytokine stimulation of the bone marrow. So left shift of the leukocytosis and hypokalemia, metabolic alkalosis, dehydration, but anemia is also there. That's why the hematocrit is not high, because dehydration will cause increased hematocrit, but anemia will decrease the hematocrit. That's why overall effect is the lower hematocrit, not the high hematocrit. Like in a dengue patient, In dengue patient, we find high hematocrit because there is a severe dehydration, but there is anemia also. That's why high hematocrit is not correct. Next question. You receive a microbiology report on intubated patient with severe acute respiratory failure and unilateral cavitating opacification on X-ray. The report suggests early growth from a recent bronchoalveolar lavage sample of PVL, penton, valentine, leukocidin producing Staph aureus. The patient is currently receiving comaxiclove for suspected community-acquired pneumonia. Clinically, he is deteriorating with worsening septic shock and oxygenation. The best choice of antimicrobial therapy would be IV flucloxacillin, clindamycin, and meropenem. Addition of intravenous immunoglobulin to the current regime, intravenous clindamycin, linezolid, and rifampicin, and consideration of IV globulin, immunoglobulin, IV vancomycin pending sensitivities, nebulized pentamidine with linezolid, and consideration of intravenous immunoglobulin. So answer is C. Okay, so everyone is giving the answer C. C means IV clindamycin, linezolid, and rifampicin are and consideration of IV immunoglobulin. Okay. So answer is correct. PVL, penton, valentine, leukocidin is the toxin, extracellular toxin produced by Staph aureus, which can be either MSSA or MRSA. Usually it's associated with skin and soft tissue infection, but it can result in the necrotizing hemorrhagic pneumonia. So rise in incidence has to develop interest in critical care perspective. So mortality is very high, 75%. And the treatment of this is vancomycin is not recommended due to poor extracellular fluid level and penetration of lung tissue. So consensus recommendation is the empirical combination therapy, clindamycin, linezolid, and rifampicin. Linezolid for toxin clearance and rifampicin for intracellular clearance of Staph aureus. And you can use 2 gram per kilogram IVIG as an adjunct for its ability to neutralize exotoxin and superantigens. Dose can be repeated at 48 hours if there is a failure of response. So PVL mortality is very high, 75%. And whenever you find necrotizing hemorrhagic pneumonia or cavitatory pneumonia, you should think about the Staph aureus. And the culprit exotoxin is the PVL, penton, valentine, leukocidin. Treatment is the clindamycin, linezolid, and the rifampicin. Rifampicin is not used in India because of the excessive prevalence of the tuberculosis. But in Western countries, the rifampicin is used for the intracellular clearance of the Staphylococcus aureus. And the IVIG should also be used as a adjunct because of to neutralize the exotoxin present. Next question is you are called to see a 35-year-old female on a surgical ward 24 hours after incision and drainage of a small thigh abscess. She is complaining of nausea and increasing pain and looks unwell. On examination, she has a tachycardia of 140, temperature 39.6, hypotensive at 85 by 30 millimeter mercury. She is sweaty and agitated. IV line in situ and currently receiving normal saline at the rate of 100 ml per hour and PCM intravenously. On assessment, she is confused but has a clear chest, normal heart sound, soft abdomen, and no obvious external wound. First priority should be intravenous dantrolene, administer beta-lactam and clindamycin, urgent CT imaging of thigh, administer intravenous immunoglobulin, arrange urgent general surgical review. So what is your take? Anybody? Answer is E, general surgical review. Okay. So answer is B. This is a staphylococcal toxic shock syndrome. So we have to administer beta-lactam and clindamycin antibiotic because earlier this staphylotoxic shock syndrome was used with the retained tampon, but nowadays this is not the cause. So usually this is considered when any condition underlying staph infection is suspected. When pain out of proportion, you should think about the toxic shock syndrome. Systemic upset is also a suggestive symptom. Early aggressive antimicrobial treatment and source control are the mainstay of therapy. So antimicrobial therapy is a dual rationale, bactericidal antibiotic and indicated to prevent spreading infection, but bacteriostatic antibiotic can result in decreased toxin production. So penicillins are recommended with the addition of vancomycin or linezolid. IVIG has a potential role but limited supporting evidence. So it is recommended that extensive debridement along with the antibiotics. This is the treatment of the toxic shock syndrome. So administer beta-lactam and clindamycin antibiotic, and source control must be there. So answer is the first priority should be to administer the antibiotics. Then you should arrange, take a surgeon opinion, and you can go for the debridement. Next is a man is admitted with a severe chest infection. He consents to HIV test. The following is not an AIDS defining illness: Mycobacteria tuberculosis, Kaposi's sarcoma, cerebral lymphoma, CMV retinitis, and oral candidiasis. Answer is E. Okay. So all A, B, C, D are the AIDS defining illness. So according to the UK national guidelines, AIDS defining illness are like tuberculosis, pneumocystis, cerebral toxoplasmosis, cryptococcal meningitis, PML, Kaposi's sarcoma, persistent cryptosporidiosis, NHL, cervical cancer, CMV retinitis. But persistent oral candidiasis is not an AIDS defining illness, but is one of the list of conditions that should prompt clinician to consider HIV testing. Okay, next is a 41-year-old female presents with abdominal pain, nausea, and vomiting diarrhea. Examination shows her to mildly jaundice, inatrial fibrillation, agitated with bibasal crackles. Observation: heart rate 134, blood pressure 76 by 45, respiratory rate 28, saturation 93%, temperature 39.6. She has mildly deranged liver function test, normal WBC count and CRP. Beta HCG test suggests she is pregnant. What is the most likely diagnosis? Thyroid storm, decompensated alcoholic liver disease, sepsis, malaria, ectopic pregnancy. Answer is A. Okay. Anybody else? So this is a clear-cut picture of the thyroid storm. So pyrexia is generally a feature of decompensated alcoholic liver disease, sepsis, because normal WBC count and inflammatory markers. So if decompensated alcoholic liver disease, sepsis is the cause, then WBC count should be high. Patient with malaria usually present fever, headache, malaise, GI, jaundice, and respiratory symptoms. Tachyarrhythmia and cardiac failure are not normally present in case of malaria. In thyroid storm, there is a spectrum of thyrotoxicosis where decompensation of organ function can occur. And this transition into the thyroid storm because of some insult like infection, trauma, surgery, myocardial infarction, decay, pregnancy, parturition. Like in this case, pregnancy is the factor which leads the patient to the thyroid storm. And pyrexia is almost universal, more than 39 degrees centigrade in an unwell patient with known thyrotoxicosis. So we should think about the thyroid storm. Cardiac decompensation because of high output failure, tachyarrhythmia, neurological dysfunction, liver dysfunction, nausea and vomiting, abdominal pain and jaundice. So these are the features of thyroid storm. Diagnosis is on clinical suspicion, and treatment: thyroid specific therapies to block synthesis, block release, block T4 to T3 conversion, and block enterohepatic circulation. So thyroid storm is a very favorite topic of EDIC 1 exam. You should read in detail of this topic. What is the treatment modality? Which drug should be given first? Then second, what is the sequence of medicine in the treatment of thyroid storm? What are the clinical features? What are the triggering factors, what is the thyroid profile. So there are a lot of questions asked from this small topic. So this topic is not big, but this has a very important role in the exam. So you should get at least one question from the thyroid storm or diabetic ketoacidosis or Sirki. So they ask these endocrine emergencies, they are very fond of asking questions from this topic. Then we move on the K-type questions. A previously well 45-year-old man is assaulted with a baseball bat and sustained a left-sided subdural hematoma. On arrival in emergency room, his GCS is 5, undergoes emergency craniotomy. Following evacuation of hematoma, he is transferred to the ICU. 12 hours later, he has a brief tonic-clonic seizure, which self-terminated. Which statement is false? In exam, you should read this very carefully, whether they are asking which statement is false or which statement is true and what is true all except. So you should read this thing very important. Otherwise, in exam, at least 2 to 3 questions are wrong because of the misinterpretation of the question. So in this question, they are asking which statement is false. SDS carries increased risk of seizure. Prophylactic phenytoin affecting and preventing early PTS. Prophylactic anticonvulsant do not reduce the incidence of late PTS. Prophylactic anticonvulsant improve outcome following TBI. It is reasonable to start the patient on phenytoin. So you have given answer D. Okay, prophylactic anticonvulsant improve outcome following. So post-traumatic surgery is defined as early or late, within 7 days, after 7 days. Risk factor, GCS less than 10, subdural, extradural, intracerebral hematoma, depressed skull fracture, penetrating head injury. Both prophylactic phenytoin and valproate effectively reduce the incidence of early PTS. Although this has not been shown to improve outcome, prophylactic anticonvulsant have not been shown to reduce the incidence of late PTS. So prophylactic and improve outcome following traumatic brain injury. So this statement is wrong. They don't improve outcome, but they reduce the incidence of post-traumatic seizure, and that is early, less than 7 days. But do not reduce the incidence of late PTS. So option B and C are correct. A is also correct because of diffuse axonal injury, there is high chances of seizures. It is reasonable to start this patient on phenytoin. Yes, this is also correct. But prophylactic anticonvulsant do not improve the clinical outcome. So that's why this option D is correct. But they are asking which is false. So this statement is false. Regarding the administration of recombinant factor 7A, which one of the following option is true? Its use is associated with 1 to 2% incidence of thromboembolic complication. It has a half-life of 12 to 15 hours. It is given in physiological doses for the management of major hemorrhage. License for treatment of major obstetric hemorrhage, refractory to surgical management. DIC is common complication. Somebody has given answer A. So correct answer is A. Incidence is 1% in hemophilics and 1.4% in non-hemophilic coagulopathy. Very short half-life. Duration of action is 2 to 3 hours. So repeat dosing may be required. And it is given in supraphysiological doses for major hemorrhage. So it's an off-label indication. And suggested regime is 200 milligram per kilogram followed by 100 milligram per kilogram at 1 and 3 hours after first dose. License indication is the hemophilia A or B and inhibitory antibodies or acquired factor 7 deficiency. DIC is rare as a consequence of this treatment. Okay, so answer A is correct. So thromboembolic events 1 to 2% incidence. Half-life is 12 to 15 wrong. Physiological doses no. Supraphysiological doses. It is licensed to treat major obstetric hemorrhage wrong. This is licensed to treat only for the hemophilia A and B and inhibitory antibodies. The following statement concerning SBP in chronic liver disease is false. The probability of survival at 2 years following one episode of SBP is 50%. Neutrophil count more than 150 is a diagnostic. Administration of albumin may decrease the development of hepatorenal syndrome. Ascitic culture is negative in up to 40% of culture. Routine antibiotic profile is recommended in patients with cirrhosis and ascites. who have had one previous episode of SPP. Okay, so what is your answer? So answer is B. Following one episode, somebody, yes. So following one episode of SBP in cirrhosis, the probability of survival at 2 years is 50%. Neutrophil count more than 250 is a diagnostic of SBP. Administration of albumin in SBP may decrease the frequency of development of hepatorenal syndrome. So for albumin, there are 2-3 indications, and one indication is the SBP. Ascitic culture is negative in 40% of SBP, causes despite sign and symptom indicative of SBP. Common pathogens like E. coli, streptococcus, enterococcus species. So it is recommended that cirrhotic patient with ascites who had one previous episode of SBP receive lifelong prophylactic antibiotics. So there are very few examples of the prophylactic antibiotic, and SBP is one of them. And class 1 indication of albumin is the SBP, spontaneous bacterial peritonitis. So SBP is a very important topic in the exam. So basically, I am trying to give you a glimpse that these are the high yield topics, and for EDIC 1, so you should read in detail of these topics, because it's not possible to cover each and everything of all the high yield topics. But in crash course, we are giving you questions related to those topics which are commonly asked in the exam. Then next, regarding the pathophysiology, management and treatment of necrotizing fasciitis. Mortality is directly proportional to time of intervention. Most common type is group A streptococcus. Skin changes are a common early presentation. Surgical debridement must be performed as antibiotics are unable to penetrate infected necrotic tissue. Clindamycin is the first line monotherapy. So what is your answer? So necrotizing fasciitis is a clinical diagnosis. First option is true. Then false. Prompt recognition are essential as mortality is directly proportional to time of intervention. Then classification, there is a type 1. Type 1 is the most common form and is a polymicrobial. Type 2 is streptopyogenes. Type 3 Vibrio, and type 4 is fungal. So this classification is very important to remember. And skin bulle, blister, crepitus, skin fluctuation, necrosis, gangrene are seen in the later stage of disease. Antibiotics are unable to penetrate necrotic tissue. So aggressive surgical debridement is the first priority. Empiric treatment, broad spectrum antibiotic like piperacillin, tazobactam or meropenem, which should be combined with the clindamycin. Clindamycin is included in antibiotic therapy to switch off toxin production. If MRSA is suspected, linezolid is preferred to vancomycin because it also inhibits the exotoxin production. So treatment of choice is the piperacillin, tazobactam or meropenem plus clindamycin. And if MRSA, so you can add the linezolid. So necrotizing fasciitis is also a very important high yield topic. And when they say in the exam pain out of proportion, so you should think 2-3 things in your mind. One is toxic shock syndrome. Another is necrotizing fasciitis. Third one is rhabdomyolysis. So these are few diagnoses in which you will find pain out of proportion. Okay. So general topic, we have covered few questions from the general topic.